Here is my presentation on evidence on effectiveness of thumb orthoses. So the purpose of thumb orthosis is to immobilize, rest, protect, position one or more of the thumb joints. A benefit is that it leaves the digits free to allow for function, and it may or may not immobilize the wrist. And then it can be long or short, and then there's spica, which means the thumb is immobilized. And really, the splints and the purpose can vary with diagnosis. Possible risks of wearing an orthosis. There can be decreased skin integrity, nerve impingement, infections, and/or pressure sores. Who would need a thumb orthosis? Someone with rheumatoid arthritis or osteoarthritis, RCL and UCL of MCP strain or post-repair, scaphoid fracture, thumb fracture, tendon transfers. Wrist arthrodesis is where like the radius and carpal bones are fused together. De Quervain's tendinosis, median nerve injury, MP dislocations, or extensor pollicis longus repair. Possible designs of thumb orthosis. It can be volar or dorsal or radial. It can have C-bar, opponent's bar, or thumb post, palmar abduction or radial abduction, and it may or may not immobilize, or it can leave the wrist free. Here's just a picture of C-bar, thumb post, and opponent's bar. Just some things to keep in mind. Thumb spica splints can extend from the thumb to the midforearm or from the thumb to above the elbow. The splint also should always allow for maximal sensory perception, and the pressure of the splint should be equally distributed. It is vital that the splint allows for balanced function and maximal mobility of the unaffected areas, such as the fingers, upper arm, and shoulder. These are just a couple pictures of what different thumb orthoses might look like. Proper positioning in a thumb splint. The thumb should be in palmar or radial abduction at the CMC between 40 and 50 degrees. The MCP should be flexed 5 to 10 degrees. The IP is free, but if it's in pain or part of the injury, then it can be blocked. And the wrist is in 15 degrees of extension or neutral. Some clinical pros and cons of thumb orthoses. Some pros being that, as you saw on the previous slide, it can be effective in many different diagnoses or injuries. It is easy to teach and for the client to learn how to use. Cost effective. Custom-made splints can be expensive, but in the long run, they do have a high effectiveness, and they're accommodating, simple to manipulate, and then they're also easy to remove for the assessment of the healing process. Some cons being that making custom splints takes time, may not be a good fit for every client, taking into consideration some client factors, especially in the education part of it. And splints can potentially do more harm than good if it's not utilized and cared for properly. So evidence on the effectiveness of thumb orthoses. The first article I found was a level 3 quantitative quasi-experimental. The purpose of the study was to evaluate the effectiveness of custom-made thermoplastic short opponent splints and educational programs on patients with symptomatic trapeziometacarpal joint osteoarthritis in daily clinical practice. The second article, also being a level 3 quantitative quasi-experimental, the purpose of the study was to compare the effect of 2 different splints on hand function, pain, hand strength, in adults with carpal metacarpal osteoarthritis. One of the splints was a prefabricated neoprene comfort cool splint, and the other one being a custom-made hybrid splint fabricated from neoprene and Rolliane Aquaplast watercolors. The third article was also a level 3 quantitative quasi-experimental. The purpose of this study was to evaluate the effect of custom-made thumb splints on pain, function, grip strength, and key pinch in patients with first carpal metacarpal joint osteoarthritis. The final article being a level 2 quantitative randomized controlled trial. The purpose of this was to evaluate the effectiveness of therapeutic ultrasound with or without spica splint in the management of de Quervain's disease. A summary of the article findings. All of the articles showed that the use of a thumb splint is effective in decreasing the following symptoms that arise from osteoarthritis: pain, hand function, pinch strength, and grip strength. And in one of the quasi-experimental, it was said that in the comparison between the initial splint application and 90 days after use, there were statistically significant differences in all of the parameters, being grip, hand function, and pain, except pinch strength. Just something to keep in mind with it being a level 3, it's a little less reliable of a study, but just something to keep in mind. And the randomized control trial showed that the use of a thermal agent, being therapeutic ultrasound, was more beneficial in decreasing and maintaining symptoms of de Quervain's when a thumb splint was added to the treatment. All of the articles also show that the use of a thumb splint improved the participants' pain during and or after use occurring from either osteoarthritis or de Quervain's. One article compared two types of splints, prefabricated and custom made. The results show that the type of splint, prefabricated or custom, did not make a difference in self-reported hand function, but the scores from the hand function assessment were improved significantly after wearing the splint, wearing the custom splint in comparison to the scores of the prefabricated splint. The third article concluded that the results demonstrate that the comfort, cool, and hybrid splint have the equivalent effect on hand function, grip, strength, and pinch strength. However, the hybrid splint, being the custom splint, was statistically significantly better than the prefabricated splint at reducing pain. So I thought that was important because we do typically make customized splints. And so knowing that they can be slightly better at reducing pain, especially in osteoarthritis. Some future research, the effectiveness of thumb splints on other conditions. 3 out of 4 articles that I found pertain to osteoarthritis, and the other one being about de Quervain's. I think just more research on the effectiveness of them on other conditions like median nerve injuries, carpal bone fractures, and tendon repairs. Also, the effectiveness and benefits of using a splint along with other thermal agents like paraffin or fluidal therapy. The one that I found was just on therapeutic ultrasound, but maybe just knowing the effectiveness of them along with other thermal agents that we've learned. And more evidence on the comparison of effectiveness in the long term between prefabricated and custom-made splints. The article showed that custom-made splints were more significantly improved pain in comparison to prefabricated, but looking at it more long term, just to see the difference there. And then my prompts are: what is a client scenario that a long or forearm-based thumb splint may be recommended over a short or hand-based thumb splint? When educating a client about their splint, what are the critical things we should make sure to discuss to decrease the likelihood of the splint doing more harm than good? And what are some client factors we as OTs should consider when educating a client on a splint, like how to put it on, how long to wear it, when to wear it, and if a splint would be a good fit for a client. And there's my references.